I want to welcome our next guest. So our next speaker is Dr. Alan Pocinki. Dr. Pocinki is an internal medicine physician with a long-standing expertise in autonomic dysfunction and related disorders. He's been a leader in this field for decades, with research and publications focusing on dysautonomia and fatigue in patients with Ehlers-Danlos syndromes. He also has been the recipient of numerous honors, including the Ehlers-Danlos Society Lifetime Achievement Award, which is a big deal. And so please help me welcome Dr. Pocinki.
Come on down. All right. So you can hit spacebar to go forward. You can hit forward here. You can use the wireless mouse, whatever you prefer. Okay. And then we're going to mic you with a lavalier.
Okay.
It's just easier. You don't have to lean into the microphone.
Do my part.
There you go. Just put it right in your pocket there. All right.
Okay, we good?
Yep.
All right. Thanks, Sina. Thanks, Dekra. Thanks for inviting me. Kudos to UVA for setting up this program, which, frankly, the idea of having an interdisciplinary EDS center where patients could go and be seen by physicians of different specialties who are knowledgeable about their conditions has been a dream of mine for a couple of decades. I don't have time to go through my 4-decade odyssey because talking about symptoms and management of autonomic dysfunction in 30 minutes is not going to be easy. So let me get started. And I do appreciate the irony of asking a bunch of people who have brain fog and don't tolerate prolonged upright posture and don't regulate body temperature well to be sitting in this cold room staring at a screen for hours. So I appreciate your bearing with me. If you need to jump up and down or wiggle or move your arms around or fidget, I won't be offended. I have no financial conflicts of interest to disclose, but I think I do need to disclose that in order to speak to you today, the university asked me to attest to the following statement. If I'm providing recommendations involving clinical medicine, they will be based on evidence that is accepted within the profession of medicine as adequate justification for their indications and contraindications in the care of patients. In fact, the advice, the recommendations, what I'm going to tell you about today is based on what the profession of medicine derides as anecdotal evidence. It's based on my decades of experience working with these patients and learning from them and figuring out what works and what doesn't. And this is not generally considered by the profession of medicine to be adequate justification for making treatment choices. But since no one's come to kick me out, I'll keep going here. The other disclaimer I tend to include here is that I used to have a cartoon in my office. I just retired a few months ago. I had a cartoon in my office that said, I'm the doctor that 9 out of 10 other doctors disagrees with. So start with the very basics. I think hopefully this is review, but so many people have talked about autonomic dysfunction. At the most basic level, of course, the autonomic nervous system regulates everything that happens automatically: heart rate, blood pressure, breathing, digestion, body temperature. Autonomic dysfunction, we all know, is very common in Ehlers-Danlos and really underlies a lot of their symptoms, which has been news to most people. So very basics. Most of you probably know this, but the autonomic nervous system primarily composed of the sympathetic nervous system and the parasympathetic system. I found it helpful to use a automotive analogy and consider that sympathetic nervous system as the accelerator and the parasympathetic as the brake. And of course, the primary job of the autonomic nervous system is to maintain what we call homeostasis, to maintain stability. And then once you're stable at a calm level, to respond to stress appropriately. So if you're trying to do something like exercise, you'll raise your heart rate and raise your blood pressure appropriately. So autonomic dysfunction, then it follows, is characterized by instability and a failure to modulate responses to stress. So, and this is what this looks like in red, white, and blue. So this is software that allows us to look at sympathetic and parasympathetic activity simultaneously. So I won't dwell on the details. I think this at rest, you see there's very, okay. Said that was a hair trigger, and I guess it is. Okay, so at rest, there's very little activity. Then we have people do deep breathing. When you're feeling stressed, you're feeling anxious, somebody takes a deep breath. Deep breathing stimulates your parasympathetic nervous system. Rest, not much. Then we have people clench and strain to simulate stress, and that triggers a sympathetic response. The most important thing here I want to show you is standing. Now, as the patient stand, there is an increase in sympathetic tone because there's a drop in blood flow to the brain, and the pressure sensors in your neck detect that drop in blood flow and bump up the heart rate and bump up the blood pressure to maintain blood flow to the brain. But that's a very transient effect, and then almost immediately, other things happen like blood being moved into the circulation from other places and blood vessels being constricted, and you don't need to maintain excess sympathetic tone to maintain blood flow to your brain when you're standing. This is what happens when an Ehlers-Danlos patient with a bad autonomic system stands. Blood flow to the brain drops, and their body overcorrects, panic. There's not enough blood getting to the brain. And so you get this sudden increase in heart rate and in blood pressure, and then the pressure sensors in your neck say, wait a minute, now things are going up too much too quickly. And so not only have you hit the brake too hard, but almost you hit the gas too hard, but then almost immediately you hit the brake even harder. And then, well, no, that was too much brake, but hit the gas again. No, that's too much gas, but hit the brake again. No, that's too much brake, but hit the gas again. And you see this person's been standing for 2 minutes and her body is struggling, trying to maintain blood flow to her brain. And you think about the energy being expended here. Look at all the energy that she's wasting compared to what a healthy person is doing just to try and maintain blood flow to the brain. And you can see, even at rest, it's just crazy. It's unstable. So actually, I should really point out this. This is really critical to understanding orthostatic intolerance in hypermobile people. The idea that you don't feel lightheaded when you stand because blood flow to your brain dropped. You feel lightheaded when you stand because blood flow to your brain dropped, you hit the gas too hard, and then you hit the brake too hard. And so this is the explanation for the paradox of being given medications like beta blockers. Why would if my blood pressure is so low, I'm feeling lightheaded when I stand up, why would I take a medicine that lowers my blood pressure? And the answer is because the beta blocker is going to blunt this upsurge, and then if you don't get this big up, you won't get the big drop. And if you understand that, you understand more than most cardiologists do about orthostatic intolerance. Because believe me, while you guys were having lunch yesterday, I was giving a Zoom presentation to a group of autonomic disorder specialists. And one of the premises that I took issue with was that patients should only be treated with low doses of beta blockers because higher doses of beta blockers make their symptoms worse, which is totally inconsistent with my decades of treating patients with these syndromes. So the hallmark is this exaggerated sympathetic stress response. And people recognize that, or people around you recognize it. Why do you make such a big deal out of every little thing? You can't help it. We talk about an exaggerated startle response. You know, the car, you space out at a red light and the guy behind you blows the horn and your heart is pounding and racing for 10 minutes. And then that over response to stress then triggers a drop. And again, that looks like what I call the autonomic roller coaster. This is crazy. So the main reason I show this slide is that to make the point that this reflects an imbalance or dysfunction of a normal autonomic nervous system. Your autonomic nervous system is not damaged. It's not permanently damaged. It's just not working properly. And this is a before and after of a patient whose underlying causes, other things that were driving her autonomic nervous system to misbehave, were addressed. And you can see that this almost looks like the normal that I showed in the previous slide. And in a little while, I'll talk about how this person got from the first picture to the second, how we do that. So over the years, my patients have found it very helpful. I thought of this construct to try to explain some of these things. So one of the paradoxes that patients struggle with is, why is it the more tired I get, the more irritable I am? Why is it the more tired I am, the harder it is to sleep? And I wrestled with this for a couple years back a few decades ago when I was working with chronic fatigue syndrome patients. It's like, these are really smart, high-achieving, well-educated, insightful people. Didn't they notice how run down they were getting? And the observation from Chip Norris's group that 70% of patients had a precipitating episode before a downturn. This is the classic story of chronic fatigue syndrome. People were humming along fine and then they crashed. Well, actually, they really weren't humming along fine. They were getting more and more and more and more run down. But the paradox is that the more run down they got, the more sensitive their bodies got to the little bit of adrenaline they were still able to make. And I wrestled this for a while. I said, why does this make sense? Why would the body do this? And the best explanation I can give you is an evolutionary perspective. Wow. Oh my God. And that is that, not that many tens of thousands of years ago, if a wild animal were chasing you and you were doing the fight or flight thing, and you were exhausted and found a rock to hide behind, try to catch your breath and hope that the animal didn't see you, and then suddenly you saw that he was coming after you again, you wanted that last little adrenaline you had left to have a maximum effect. And most particularly, you didn't want to feel tired and you didn't want to feel pain. And so this is a major problem in these syndromes, that as long as your stress levels are high and your body's cranking out adrenaline, you tend to not realize how tired you are, not realize how much pain you're in, often not realize how depressed you are. So this is what my energy pool construct looks like. And this, in a nutshell, is how the previous patient got off the autonomic roller coaster, got from chaos to a normal function. And say, we know that the tank is empty. Why is the tank empty? Because sleep quality in this syndrome is terrible. People don't realize that, and unfortunately, there are sleep studies that are markedly abnormal get read as normal. Sleep quality is terrible. I gave a whole lecture to Jeannie DeBond's group a year ago on the theme of misperception. You don't know what a restful night's sleep feels like if you've never had one. So sleep quality is terrible, and that's your major chance to put gas in the tank. Now, good nutrition will help put some in. If you're deficient in certain nutrients, that'll put some energy, but sleep is the big thing. And then this slide was only big enough to hold this many energy drains, but there are more. So pain is a big one. Again, people tend to underestimate how much pain they're in. Pain sucks up your energy, and pain ruins the quality of your sleep. So really addressing pain is key. Fatigue itself is a problem because every time you're exhausted and you push through it because you've got to do something, you've got to pick up the kids from school, you've got to finish a paper, you've got to meet a deadline, you're dipping into the reserves to do that, and you're making your dysautonomia worse. So do something, rest, try to conserve energy, try to take breaks. Dehydration, if you're a little bit lightheaded, if you're a little dehydrated and you're lightheaded when you stand up, your body's got to kick in some adrenaline. It's got to draw down that tank again to maintain blood flow to your brain. Cognitive effort, your brain uses just as much energy as your body does. Cognitive tasks are tiring, and they need to be budgeted into your energy budget for the day. Emotional stresses obviously are draining. Work and school stresses. I could add financial stresses. Clearly, the chaos in the world around us is stressful. I live in the DC area where driving anywhere at any time is stressful. And you can see here, I think, as somebody alluded to this yesterday, that this is not unique to the Ehlers-Danlos community. There are way too many people in our community who are trying to get by with not enough sleep and are totally stressed out. And it's a big problem. The other point I want to make is, from my perspective, when I see somebody who's having autonomic dysfunction, I want to know what is driving it. What is causing their autonomic nervous system to misbehave? It's not just, oh, you're having palpitations when you stand up, here's a pill to reduce your palpitations. There's something underlying it. And that's not a concept that I see, unfortunately, in the dysautonomia community. So a lot of people in the dysautonomia community actually say education is the most effective treatment. an educated physician can help explain what's going on and reassure people that they're not imagining this, reassure your family and loved ones that you're not, that you really can't help it when you overreact to every little thing. And for patients, education helps them understand what's going on, manage their symptoms, not feel overwhelmed. So this is, again, when I talk about what's driving autonomic dysfunction, what's causing your autonomic nervous system to misbehave. This is a cycle that, again, applies to a lot more conditions than more than just Ehlers-Danlos. But this vicious cycle of chronic pain, poor sleep, fatigue, and depression driving autonomic dysfunction is one of the reasons it's so hard to break the cycle, to get out of this. Because each one of these things aggravates the others. And in our modern medical system, you know, you may have one doctor addressing your depression and one doctor managing your pain. Nobody knows anything about sleep. Nobody really knows anything about dysautonomia. And how are you gonna break this cycle? So I don't have time to go through the entire body and all the manifestations of autonomic nervous system dysfunction. A lot of people, my previous speakers, have touched on this. I'm going to mention the two sort of most common. In the central nervous system, brain fog is an issue. Most of us pretty firmly believe that brain fog is related to inadequate cerebral perfusion. And one of the speakers this morning showed some data from Peter Rowe's study of chronic fatigue syndrome patients showing decreased blood flow to the brain. There was an elegant study that I hesitate to do things like this because it tells you how old I am, but in the early 1990s, a physician named David Streeton, who was about a decade ahead of everybody else in understanding or even thinking about the autonomic nervous system, took a group of fibromyalgia patients and put large blood pressure cuffs on both arms and both legs and partially inflated them to decrease blood flow to the arms and legs and increase blood flow to the brain and the vital organs. And guess what these patients said? My brain fog's gone. The question this morning was, does decreased blood flow affect pain? Yes, these people said, my pain is gone. So, and the geniuses at the FDA said, we need you to do a sham placebo-controlled trial of this. So the other thing that comes up very often that I give a whole hour-long presentation on is mistaking autonomic symptoms for psychiatric symptoms. Something stressful happens and you get a huge adrenaline surge, your chest is going to be tight, your heart's going to race, you may feel short of breath, you may even get a little queasy and a little lightheaded, and you've just met the DSM criteria for a panic attack. I also see people even misdiagnosed as hypomanic. If you're exhausted and stressed and running on adrenaline, and you make the mistake of saying to a physician that, you know, I only slept 2 hours last night and I worked all day today, they're going to think that you're manic. And then ADD and ADHD are almost certainly, in my book, these are not psychiatric problems. These are autonomic problems. And the FDA approval of drugs like clonidine and guanfacine, which are not stimulants, they're adrenaline suppressors. I had hoped was going to get more people to recognize this, but not really. Body temperature dysregulation is a pain, sensitivity to auditory stimuli and visual stimuli and vestibular stimuli. It's hard to maintain balance. Most of my patients can't go near a shopping mall or anything that's, you know, I can't go to a hockey game anymore. The light, the sound, it's just overwhelming. And then non-restorative sleep is a huge and underappreciated factor in fatigue and autonomic dysfunction. So I'm going to talk some more about sleep, cardiovascular stuff. Again, a lot of people have talked about that. It's lightheadedness. The one point that I want to make here is that not all orthostatic intolerance is POTS. A lot of physicians make that mistake too. And then if they read the literature on POTS, they'll read certain do's and don'ts, what to do with your POTS patients that isn't applicable to this patient group. So I don't have time to go through all the criteria for all the different orthostatic names of the different types of orthostatic intolerance, but okay. And I just wanted to add this because this is something that is really common. I used to estimate that about 15 to 20% of my dysautonomia patients had fluctuating blood sugars as a manifestation of their dysautonomia. In recent years, I've doubled that. The more people I ask about, the more people would tell me stories of, I needed a note from my mom to have a snack in the middle of the morning. When I was in elementary school, clearly there was no insulin resistance going on at that age. And this is, there's one small paper in the literature on this, but the dysautonomia community is starting to recognize this. GI problems, basically either too much sympathetic tone, you're doing the fight or flight thing, your gut shuts down. When that wild animal is chasing you, you don't want to stop and have to go to the bathroom. And if your parasympathetic nervous system overreacts to eating, then you've got the runs, cramps, gas, bloating, and diarrhea. Urinary symptoms are tricky. A few other people have mentioned them. There can be autonomic problems, but urinary dysfunction very often is related to bladder, is related to pelvic floor dysfunction. When we see more serious issues like incontinence, we worry about tethered cord, interstitial cystitis, the whole other. So just like when I see patients with GI problems, I tell them, the odds are you don't just have one thing wrong with your gut. The odds are you have 3 or 4. So autonomic nervous system dysfunction can play a role in bladder problems, but there's other factors there too that need to be looked for. And then, every other system, I'm not going to go through these for the sake of time. Do want to say a word about diagnostic testing, even though my title was symptoms and management. Basically, back to my disclaimer. My advice on diagnostic testing is don't do it. The basic nature of dysautonomia is that your autonomic nervous system is unstable. So you can have a gastric emptying test one day that's normal, and the next day it's not. You can meet criteria for POTS in the morning, not meet criteria for POTS in the afternoon. Tilt table testing is cruel. And finally, people in the dysautonomia community are coming around to that. I think I even put in a slide here of, asking somebody with vertigo to go through a revolving door is what I think about, gee, you're lightheaded when you stand up, let's strap you on a table and leave you there until you pass out or throw up. It's really not necessary. Urodynamic testing is really only helpful if you're concerned about tethered cord. And then these are tests for sweating function. Most people know whether they sweat normally, whether they sweat more or less than other people. They don't need to do that. Polysomnography, sleep study in a sleep lab. Nobody sleeps normally in a sleep lab. Fortunately, the home monitors have gotten to be pretty good. So the one other thing I want to say about POTS is, and this is my colleague David Goldstein is fond of saying, the most important part of POTS is the S. It's not just postural orthostatic tachycardia. It's a syndrome of lots of other autonomic symptoms. And the other thing, again, most of my patients with either EDS or hypermobility spectrum disorder who are lightheaded and standing do not meet criteria for POTS. So they have orthostatic intolerance. So treatment is basically this guy. How do you get better? Again, sorry. Boy, try to figure out what's going wrong with your sleep, and then made the point that a lot of this stuff, yeah, you're going to need some medicines probably to get your pain under control, but a lot of this other stuff is lifestyle, limiting your stresses, not pushing through fatigue, staying adequately hydrated. So this is not all about taking pills. And that's the woman who's watching the television and the ad on TV says, ask your doctor if taking a pill to solve all your problems is right for you, if only. And similarly, I like this one. This was designed to be a joke, I think, but in fact, hugging a friend, a family member, a pet, even a stuffed animal, increases production of feel-good neurotransmitters like endorphins and dopamine. So simple things. So in terms of orthostatic intolerance, two-pronged approach, maximize effective volume. So obviously, if you're lightheaded on standing quickly or standing for a long time, don't do it. graded exercise program, the better your muscle tone, the better your vascular tone, the less what we call pooling, the less your blood is kind of sitting around. Adequate salt and fluid. I just need to say that I did some testing a few years ago with a number of my patients who had orthostatic intolerance, and I found that they all said, oh yeah, I'm drinking lots of water and I'm eating lots of salt. 90% of them were getting too much water and not enough salt. So if you're thirsty all the time, it's because you're drinking too much water. And I'd love to share this data with you, but I don't really have time. Elevation is helpful. Compression is helpful. Most of my patients just need more salt and less water. I have very rarely ever prescribed fludrocortisone. It tricks your kidneys into holding on to salt and water. There's nothing wrong with your kidneys. They would hold on to more salt if you gave it to them. Similarly, DDAVP causes your body to hold on to water. You don't need to hold on to water. You need less water, more salt. So, and then the other, in addition to maximizing volume, we want to reduce this craziness that's just wasting energy and making and perpetuating your dysautonomia. So again, there are medications, but trying to avoid the stressors obviously is better than trying to treat them. Midodrine is a drug that raises blood pressure. So when you go, you don't come down quite as far. It kind of raises the floor, but it only lasts 3 to 4 hours. So you're kind of just making this worse. Stimulants are helpful if you're somebody who always has really low blood pressure. They can raise your blood pressure a little bit and raise your heart rate. The mainstays of treatment for me, as I mentioned, are beta blockers and drugs like clonidine and guanfacine, which rather than blocking adrenaline sort of prevent you from making it in the first place. Again, the idea is to not have this big surge that causes the drop. Vabradine is a drug that lowers heart rate without lowering blood pressure. And the problem I see there is that this is routinely prescribed by cardiologists because they're afraid that if they give somebody who has got low blood pressure and lightheaded as a beta blocker, it's going to make their blood pressure lower. When in fact, that is not the case. And I wish I had time to present you some cases that I presented yesterday at an autonomics conference. But, and then pyridostigmine is an interesting drug that works by increasing parasympathetic tone. So it can not only damp out your crazy sympathetic nervous system, but if you're somebody who's got an issue with delayed gastric emptying and constipation, it can increase GI motility. Sleep disorders, I would love to have time to go through all this. Let's just say normal sleep cycles through. Typical Ehlers-Danlos patient does not cycle through deep. This is deep sleep, this is REM. This person, what you can't see here is that in the sleep lab, we define an awakening as a disruption to the continuity of your sleep that lasts more than 30 seconds. Turns out most people have to be awake for 2 minutes to remember having been awake. So she remembered waking up twice. She actually woke up 23 times. If the continuity of your sleep is broken for less than 30 seconds, we call that an arousal. She had 125 arousals. And so her sleep was literally disrupted every few minutes. And this was read as, in her sleep study was read as normal by a board certified sleep doctor. And so if you say, what's going on here? Again, this is just a reminder. Say, don't believe conventional wisdom. It doesn't apply to you. And you say, what's going on with all these arousals? Well, here's heart rate spikes every time this person wakes up. Here's somebody who, for whatever reason, her autonomic nervous system was calm and quiet, and she had a nice, almost uninterrupted chunk of deep sleep. But the rest of the night, you could use a ruler and see that every time her heart rate spikes, she wakes up. And then, very importantly, idea that this is a two-way street. Improving autonomic function will improve your sleep. Improving your sleep will improve your autonomic function. This is basic. I think I just want to get on to using medications. Multiple medications you'll need to straighten out your sleep. You'll need probably some pain medication because people are more pain than they realize overnight. You may need something to increase deep sleep. You may need something like a beta blocker at bedtime to reduce the arousals. Once you find the right combination and you're getting a restful night's sleep, then you have more energy, then you feel better, then you sleep better, then all the other pieces fall into place. Bunch of different medications that we use. The one thing I wanted to highlight here, I wanted to show you. So this is somebody's
in the sleep lab, and you can see that he woke up 25 times. You can't see all the arousals. This is what his first generation sleep monitor looked like. Basically, he was waking up about every 90 seconds. So his sleep monitor that was taking a reading every 2 minutes thought he was awake for long periods of time, when actually he was awake, asleep, awake, asleep, awake, asleep, awake, asleep. And I said, this has got to be adrenaline that's keeping you awake. I put him on propranolol, a beta blocker at night, and this is what his sleep looked like a few months later. And so this was an early case where I said, okay, this really makes sense to me. And one brief word about mast cell activation syndrome. A lot of patients are put on H1 blockers like Zyrtec or Allegra and H2 blockers like famotidine, not realizing that histamine in the brain is a very stimulating neurotransmitter. And the newer H1 blockers are designed not to cross the blood-brain barrier, so they don't make you sleepy. So you may be blocking histamine in your skin and your respiratory tract and your GI tract and leaving extra histamine running around your brain unchecked and messing up your sleep. So, and that's just, this is Jeff Boris, a colleague, has a adolescent POTS practice. He asked them about mast cell symptoms. 70% of his POTS patients had mast cell symptoms. When he treated them, not only their mast cell symptoms, but their POTS symptoms got better. I just mainly wanted to point out that that most of them, 90% of them, did not meet formal mast cell diagnostic criteria. So don't worry if you don't meet the criteria for heads, if you're one criterion short. Don't worry if your heart rate goes up 28 points and it's supposed to go up 30 for POTS. It doesn't change what you have. And so I think I'll leave you with that. I had a few quotes from patients along the way, because physicians would say, well, where's your data? And I used to have a slide, so the only data I have are the two-legged kind. Patients came back and told me how much these medications were helping them. So, but if you were to go to PubMed or even go online and look at using beta blockers in sleep, what you'll find is that beta blockers are bad for your sleep. There's nothing in the literature about this. So, summary, I think, sorry, I ran over time a little bit. So there's no way I could do this in 30 minutes. I told Decker that. So, this autonomic dysfunction, this roller coaster, that sleep disturbances are underappreciated and really fuel a lot of this. Pain is undertreated. That fuels a lot of autonomic dysfunction. Think about the cartoon and all the stresses that are depleting energy from your tank and how you might mitigate or ameliorate some of them. And if you can reduce some of those daytime stresses, maybe use a beta blocker or some other medication to minimize the fluctuations, improve your sleep, gradually replenish the pool, that's how people with hypermobility and dysautonomia get better. So thanks for your attention.
Thank you so much, Dr. Pocinki. We have time for one question. I got it right. Well, yeah, quick. Go.
I have two questions. I have to go home, so I'm going to try to be really quick, but I'm kind of like everything you just said in that presentation, which I'm sure a lot of us are, but there's something specific that was missing. And I know you're familiar, but I just don't know if you have any data on it. I have positive criteria on an MSLT for narcolepsy. Do any other patients have narcoleptic symptoms with MCAS? You have the diagnosis. Okay. Like, do you know anything about that connection? And then my second question, going to be quick. I come from a family of dentists, and so I'm trying to educate them on what that means for me as, their daughter, granddaughter, and niece. I'm in Leesburg, the Mayo Family Dentistry. When I say this thing hurts in my mouth, or they're working on another patient and they need to use increased, like analgesics or like local anesthetics, how do you get that across? Because dentistry, there's the periodontal type, but it gets left up a lot here, and the jaw is a lot, the face is a lot.
Yeah, I kind of thought that would come up in the presentation on sexual dysfunction. That failure of local anesthetics can be a big problem in delivery also. I had in my office
there are 3 papers now in the literature on failure of local anesthetics in hypermobile people. In fact, the original paper in '91 proposed that as a diagnostic criterion. It was so characteristic. And then Alan Hakim's group published this in 2015. And then just a year or 2 ago, we did a big survey monkey of, I think, 1,500 EDS patients, and I think 2/3 of them reported problems with. So I would sometimes have to give people copies of these papers to take to their dentists. I mean, it was just, it's frustrating. Sorry, the first question. Oh, narcolepsy. Yes. So the irony is that one of the drugs that a lot of people find helpful is modafinil, which is a drug that improves wakefulness. And as some of my patients, one of my patients, I thought put it very well, it didn't give her more energy, but it made her be more productive with the energy she had. And it's not physically stimulating like the stimulants. The problem is when it was a new drug, it was $700 a month. And insurance would only cover it for sleep apnea and shift work and narcolepsy. So the good news is that if you've had crummy sleep for a long, long time, you can very well have a false positive multiple sleep latency test for narcolepsy. And I have many times sent people for multiple sleep latency tests hoping that they would be misdiagnosed with narcolepsy so that I could get their modafinil covered. So yeah, narcolepsy is a different animal, and with very few exceptions, the hypermobile people I've seen diagnosed with narcolepsy don't really have narcolepsy.